Okay, to start with something that you have already done, you have studied brachial plexus. I don't know whether this disturbs your view. You have studied brachial plexus, and I'm not going to discuss brachial plexus again, but few points need to be stressed once more before we continue the discussion. Otherwise, you will be lost. Now, one point that you can see here is when you look at this picture, uh, you can see that. Hope this is getting recorded. Yes. Now you can see that the brachial plexus starts from C5 and ends at T1. So it's the spinal segments C5 to T1, which you cannot forget. Okay. So no point in knowing small details if you have forgotten this thing. Okay. So brachial plexus is from C5 to T1. So first thoracic segment is also included. That is one thing. Then the second point is that all these segments C5 to T1 are taken into the upper limb. They are totally taken into the upper limb. Therefore, you don't find these segments outside in the trunk and the neck. Okay, we'll see that. If you look at the dermatomal map, you know what are dermatomal maps. There's a dermatomal map for the upper limb and lower limb done by the departments. There are variations between books. So you must have got them by now. So if you look at the dermatomal map, you will see this fact. C5 and T1. From C5 to T1, spinal segments are not found elsewhere in the body. They are all in the upper limb because they were taken into the upper limb through the brachial plexus. So that is one point that you cannot forget. Remember this point forever. Okay, until you die. Okay. Then the other point is that in summary, you know that the brachial plexus has roots within inverted commas, because true nerve roots are within the spinal canal, not outside the, within the vertebral canal, not outside the vertebral canal. So these roots are within inverted commas because they are the beginning of the brachial plexus. That's why you call them roots. Then you have trunks. Okay, then you have divisions at this level, and then you have codes. So I'm not going behind roots, trunks, and divisions, but my interest is with the codes. Now, there are three main codes. There's a lateral code here. There's a lateral code here. Then there's a posterior code here, and then there is a medial code. From each code, three branches are given. From the lateral, from each code, branches are given. From the lateral code, there are three branches given. Posterior code 5, medial code 5. So it's 3, 5, 5. That's how the branches are given. Lateral code, 3 branches. Posterior code, 5 branches. Medial code, 5 branches. That's how the branches are given. Names of these branches you can remember. Some of the branches are not very important, like the medial cutaneous nerve, the arm, forearm. Not that they are 100% not important, but other things are more important than those things, the main branches. Okay, so you should know the main branches by now. Okay, so that's one point that I wanted to raise. Then this point, sometimes, you know, in MCQs this is checked. I don't know how much important it is to know it that way, but conventionally, you know, we teach this. There are certain nerves, certain branches, even before the codes are given at a later stage. Codes are given at this level. Even before that, certain branches are given of. Now, very early branch, one of the very early branches is the dorsal scapular nerve. You can see it here, coming from the upper, the first nerve root, C5 nerve root. So it carries C5 spinal segment. Then there are other nerves that are coming from the roots, like nerve to subclavius, coming from the C5 and C6 roots. It's actually shown here. So it's from this one and this one. Okay. And then you get this long thoracic nerve from C5, 6, 7 roots. You can see the long thoracic nerve here. Now, long thoracic nerve is more important than the previous two I mentioned, because that nerve supplies the muscle, the serratus anterior. When you damage this nerve, there is a clinical condition called winged scapula. We will look at these things in the next few slides. Then there's another point. There is from the upper trunk. You get the previous ones are from the roots here. So from the trunks, you get suprascapular nerve from the upper trunk. Again, the suprascapular nerve is an important nerve because that supplies the supraspinatus and infraspinatus muscles in relation to the scapula. Okay, so if you damage suprascapular nerve, supraspinatus muscle will be paralyzed, and the initiation of the shoulder abduction would be affected, especially the first 15 degrees. You know these things, I hope. Okay, then I think I have to remove this distance. Okay. Okay, so then when it comes to spinal segments of main nerves, now before you go to spinal segments, remember the main 4 nerves that supply the upper limb. Main 4 nerves that supply the upper limb are the musculocutaneous nerve, which supplies the flexor compartment of the arm. I have written it down here, flexor compartment of the arm. Then the median nerve is the other important nerve, and then the ulnar nerve. Now the median and ulnar nerves, they supply the flexor compartment of the forearm and the intrinsic muscles of the hand. So details of their supply, which nerve supplies which muscles and so on, you should know by now. Anyway, we will partly touch them during this lecture. Then the 4th nerve is the radial nerve. It supplies the extensor compartment of the arm and the forearm. Extensor compartment of the arm and the forearm. It does not supply intrinsic muscles as such, because all the intrinsic muscles are supplied by the median and the ulnar nerves, if I remember it correctly. So remember this point. That is the first thing you need to remember about the main nerves supplying the upper limb. Then when it comes to segments, it's easy to remember. Now, if you take the musculocutaneous nerve and ulnar nerve, musculocutaneous nerve contains the first 5, it carries the first 5 segments of brachial plexus, C5, C6 and C7. C5, 6 and 7. Then the ulnar nerve carries last 3 segments of brachial plexus, C7, C8 and T1. So it's easy to remember. Okay, 5, 6, 7, then the 7, 8 and T1. Median nerve and radial nerve, they carry all spinal segments carried in the brachial plexus from C5 to T1. You can see that. Okay, so it's from C5, C6, C7, C8 and T1. Okay, so both nerves, the median nerve and the radial nerve, they carry all spinal segments. Now, when it comes to ulnar nerve, this one, again, you know, some textbooks, they give different versions. It's not wrong. Some textbooks mention that it's only C8 and T1, which is not wrong, but it is possible that it carries C7 as well. So I added this. Actually, I got this picture from Richard Snell anatomy book. Then I corrected it. Okay, so he only gives C8 and T1, but C7 also can be included, because especially, you know, when it comes to wrist flexors and especially wrist flexors are supplied by C6 and C7. So ulnar nerve supplies some of the wrist flexors, so it has to carry C7 to supply them with. Okay. Okay, so this is about this slide. Remember this point. These are all important points. Then innervation of some of the shoulder muscles, I will show you one by one. Now I have to draw one muscle here. One muscle is missing here. Teres major, If I draw it, it would be something like this. Okay, teres major muscle. Okay, which is missing in this picture. Teres major muscle. Now the suprascapular nerves, as I just mentioned, I said it's coming from the upper trunk of brachial plexus, and it is related to the suprascapular notch. I don't want to change the presentation here, but let me yeah. So I think you can see it. This is the suprascapular notch here. Okay, this is the suprascapular notch. Okay, this is the anterior view of the scapula. Okay, this is the suprascapular notch. So suprascapular nerve passes through that suprascapular notch, and it supplies the supraspinatus muscle, which is in this supraspinatus fossa here. Okay, so this is supraspinatus muscle. Then after supplying the supraspinatus muscle, it comes under cover of this and enter the infraspinous fossa and supplies the infraspinatus muscle there. Okay, so that is the okay. Sorry, this is subscapular nerves. No, sorry, I'll put all that. Okay, so I was referring to this one. Okay, suprascapular nerve supplies supraspinatus and infraspinatus. Then the subscapular nerves, which you can't see here, subscapular nerves, they are given from the posterior cord. They supply the subscapularis muscle, which is this one, subscapularis muscle, and the teres major muscle. Teres major is the new one that I drew here. Teres major and subscapularis muscles are supplied by the subscapular nerves. Then the axillary nerve, which is an important nerve, axillary nerve, it supplies the deltoid and teres minor muscle. So teres minor is seen here, teres minor in the posterior view. The deltoid is the muscle that covers all the attachment of these muscles. You know how the deltoid is attached. Deltoid is here. Okay. So these two, the teres minor and deltoid, are supplied by the axillary nerve. Then the other important point here is that all these nerves, so subscapular nerves, suprascapular nerve, and axillary nerve, all three nerves, they carry C5 and C6 spinal segments. C5 and C6 spinal segments. Why it is important? Later, you will see when we discuss brachial plexus injuries, there are certain brachial plexus injuries where you get the upper nerve roots damaged, upper nerve roots are C5 and C6. So if you damage at the brachial plexus level, if you damage the C5 and C6 roots, all these nerves will be affected. Okay. So all the muscles supplied by these nerves, therefore, will be affected, and all the functions of these muscles will be gone. So you get the deformity accordingly. Deformity is the defect that you get, that you see outside. We will discuss these things in a moment. Okay, so that's why I raised this point. Okay, these three nerves carrying C5 and C6, because to come to that clinical point later. Then another important point that you should remember for your life is, you learn all these dermatomes, upper limb dermatomal map, lower limb dermatomal map. Then in the trunk, again, you can see there are dermatomes in the trunk, in the chest. And if you continue, it goes like that, like a zebra in the anterior, on the anterior abdominal wall. Then it goes into the lower limb, and even in the neck, you get segments like that. And when it comes to the face, you only get one spinal segment, C2, over the masseter on the lateral side here. You get C2, but otherwise it's all cranial nerves. Okay, it's all cranial nerves that supply. Actually, it's the branches of the fifth cranial nerve. You will learn these things later. Okay, but this is an overall picture that you have to know. So these dermatomes, you learn dermatomes for a reason. Now, then you have to remember this point that I mentioned earlier. Now you can see, if you look at this carefully, now this is in the neck, there is C2, then in the neck you get C3, then this is C4. So this is the upper part of the chest, upper end of the chest, and this is the tip of the shoulder. Okay, so that whole area is supplied by C2. You can see this. Now, if you take this point, I don't know whether you have learned this, that is called uh, manubriosternal junction. Okay, or you call it sternal angle. You can check these things in the internet. Manubriosternal junction or sternal angle. Actually, you can see it in the chest somewhere here. Okay, so if you run your finger over the middle of the chest in front, you will find this slightly angulated area in relation to the second costal cartilage, which is called the manubriosternal junction or sternal angle. Okay, I will not write them. This position is not very good to write. Okay. So then the point here is that at the manubriosternal junction or sternal angle, you can see that if you come from below upwards, if you go in that direction, here you get T2, then at the junction it changes to C4 immediately, jumps from T2 to C4. The reason you know, because from C5 to T1, all the spinal segments have been taken into the upper limb. All the spinal segments have been taken into the upper limb, and even the cutaneous branches, the cutaneous supply is taken in, and you can only see them in the upper limb. So if you draw the upper limb like this, down, okay, with the fingers, then you have C6 here, then you have C7 here, then you get C8, T1, and at the flow of the axilla you get T2, T2. So this band continues here into the flow of the axilla. The skin at the flow of the axilla is supplied by T2, and that nerve is called intercostobrachial nerve. Intercostobrachial means intercostal nerve continuing into the upper limb area, intercostobrachial nerve. So that's how the segments pass. If you have the dermatomal map, you can check that. I'll come back to this later in the next picture. Okay. So then the important point here is, which you will not need now, but you will need later when you do the neuro module, is that when you want to look for spinal cord injuries, especially, you check the sensory levels. You check what is called sensory levels. I'll come back to this. You look for sensory levels. Read the text here. You look for sensory levels. When you look for sensory levels, actually what you do is you start from below, from the foot area, and come up, checking the non-spinal, the dermatomes. Then when you come up like this, if you find that at one area, say at C4 level, if there is no sensation, then that is the sensory level that you get. So then, accordingly, you can find out the spinal segment that is damaged. You will learn these things later. But the point here is that when you come up like this, the moment you come up to T2 segment, that is the sternal angle level, you cannot continue like this into the neck. Okay. If you do that, you will miss a nerve defect. You will miss a sensory level, because sensory level could be in the upper limb here. So always when you look for sensory levels later on, when you do the neuro modules and later when you do the clinicals, you have to go to the upper limb. You go on the medial side, then you come up on the lateral side like this. Then come up to the tip of the shoulder, then go to the neck and go up. Okay. So remember this point. So when you go towards and when you look for sensory levels, always go through the upper limb and enter the neck, rather than going directly from the chest to the neck. So that's the point that you need to learn at this point very early. Okay. Then the other point that I want to raise here is that this C4, which supplies the tip of the shoulder, C4 is not part of the brachial plexus. You know that. So where do you get this C4 from? It's through the suprascapular nerves. Suprascapular, supraclavicular nerves. You have the clavicle here. Okay, nerves coming over that are called supraclavicular nerves. And the supraclavicular nerves, there are several of them. They are branches of another nerve plexus here, which is called cervical plexus. Cervical means they are in the neck. Cervical plexus of nerves. So one branch from the cervical plexus is the several branches, supraclavicular nerves, which supply the tip of the shoulder. So in brachial plexus injuries, actually the tip of the shoulder is spared. Okay, if the upper roots are damaged, it's the C5 that goes first, not C4. And about the C5 we will discuss in a moment. Okay. Okay, then remove this video thing again. Okay, now concentrate on this picture now. Here you can see the hand, the palmar side and the dorsal side, palmar side and the dorsal side, anterior posterior sides of the hand. You can see these six important dermatomes. So when you look for sensory loss, okay, or when you look for sensory levels, as I said before, you will always remember that C7, the landmark, important landmark is C7, the cutaneous nerves carrying C7 spinal segment supplies the middle finger. Okay, middle finger is C7 always. If the middle finger is C7, lateral to that is C6 and medial to that is C8. So thumb and index finger C6 and the ring finger and the little finger are C8. So it's very easy to remember. This is something that again you cannot forget. Okay, these are very, very basic stuff. So both sides you can see the dermatomal supply C6, 7 and 8 from lateral to medial. Then there's an interesting point. Now, then it's not only segments. The segments are brought through branches of nerves. So if you go now, the musculocutaneous nerve is in the upper part. Now it does not come into the hand area. In the hand, the other three main nerves are represented. All three nerves are represented in the hand. Now, if you look at the anterior aspect again, anterior side, you can see that the lateral 3.5 fingers, including the thumb. Okay, so this is the dorsal aspect. Okay, this blue one. So it's the anterior side. If you turn the thumb this way, okay, it should be all red. So the lateral 3.5 fingers supplied by the cutaneous branches of the median nerve. Cutaneous branches of the median nerve. And the medial 1.5 fingers is supplied by the ulnar nerve. I don't know whether it's clear to you in the video. It's the ulnar nerve supplying this area. Okay. And then when it comes to the dorsal or the posterior side, you can see that the radial nerve is supplying the lateral, 3.5 fingers, but the distal part of the fingers are all supplied by the median nerve here. Only this part is left for the radial nerve. Anyway, it contributes to the posterior aspect. Then you can see the ulnar nerve. It's not replaced by radial nerves. Ulnar nerve supplies the fingers as well as the dorsum of the hand. Now, the important point here is that if you overlap the two pictures, if you overlap this picture with this picture, I mean the both, okay. If you overlap these two, you can easily work out that the median nerve, which is this one, carries C7 and C6 to the hand. And it is the ulnar nerve that carries C8. Okay, it is the ulnar nerve that carries C8. Okay, C6 and C7 are carried by the median nerve. And then if you go by these two again, on the posterior aspect, radial nerve brings C6 and C7 to this area. Okay. So that's something that is interesting. Usually it's not mentioned in books in that way. That's why I mentioned it. Okay, but if you overlap the pictures, you can work out. Then the other thing is, if you damage the radial nerve, totally, don't go away with the idea that you will get anesthesia over this whole area. Okay, even though it's colored blue and mentioned radial nerve, because there are a lot of overlaps between the median nerve coming and supplying here and the ulnar nerve going and supplying there. Because of this median and ulnar nerve overlap with the radial nerve, if you damage the radial nerve, it would be a very small area here that would be actually that would have lost sensation. So anesthesia, you call it anesthesia. This is actually over the anatomical snuff box area. Okay, if you read Harold Ellis. There is a nice picture there to show the sensory loss in radial nerve damage. So it can be variable. In some people, you might have a larger area of loss. Okay, it all depends on the degree of overlap. Okay, but it can get limited to a very small area over the anatomical snuff box because of this overlap. Okay, so these are all clinically relevant points. Because somebody asked whether we talk about clinical points here. So these are the clinical points that I mentioned. Okay. Then two clinical conditions, dropped shoulder. I'll show you. Now, if you draw the shoulder lines here in red, you can see on the right side, the shoulder has dropped from the line if you compare with the left side. Now, this reason for this dropped shoulder is paralysis of trapezius muscle. Paralysis of trapezius muscle. You know, it's a large muscle. It's a triangular muscle attached to the vertebral bodies here, going into the neck and coming and getting attached to the spine of the scapula, acromion, and the posterior surface of the lateral side of the clavicle. So it's a muscle like this. So it has an action to pull the scapula up. So when the trapezius is paralyzed, you get this dropped shoulder. Now the trapezius is not only trapezius, there are two muscles, sternocleidomastoid, anterior neck muscle, and the trapezius. Trapezius, they are both supplied by what is called the spinal root of accessory nerve. Spinal root of accessory nerve, which is actually a cranial nerve. It's the 11th cranial nerve. 11th cranial nerve. But mind you that this 11th cranial nerve, even though you call it a cranial nerve, actually the spinal root of the 11th cranial nerve is actually something that originated from the upper cervical spinal cord segments, upper cervical spinal cord segments. It goes into the cranial cavity and comes back after uniting with the cranial root of accessory nerve, which is actually the true cranial nerve. But can't help, you call it a cranial nerve. It's called the spinal root of accessory nerve. It supplies sternocleidomastoid and trapezius. When that nerve is damaged in injuries of the neck, in neck injuries, injuries to the lateral side of the neck, or during surgeries, you can damage this spinal root of accessory and you can get paralysis of trapezius more than the sternocleidomastoid muscle, because the sternocleidomastoid is supplied before the trapezius. If you have the neck like this, sternocleidomastoid is here, trapezius is going there like that. So this muscle is supplied somewhere here and then it passes across here. So here, if the nerve gets damaged, it's mainly the trapezius that gets paralyzed rather than the sternocleidomastoid. Okay, that's why only this muscle is mentioned here. You will learn some of these things later if it is difficult. Okay, then winged scapula. I mentioned this before. Now in this picture, you can see this person is pushing against a hard surface. In this case, it's a wall. He's pushing, you can see he's pushing against a wall from both hands. You cannot see the left hand is covered by the body of the person. So when you push against a wall like this, what you can see here is very clearly the vertebral border or the medial border of the scapula on the right side has come out. Okay, it has come out like a wing of a bird. Now the reason is that this vertebral border, there's a muscle called serratus anterior attached to this vertebral border from the anterior side, not from this side, but from the other side. And it is attached to the upper 8 ribs in the rib cage. And the action of serratus anterior muscle, is to pull the vertebral border of the scapula towards the rib cage so that it's kept in place. But when the muscle is paralyzed, especially when you push against a hard surface like this, you get the winging of the scapula, okay, or pulling up of the scapula, whatever you call it, okay, jutting out of the vertebral border of the scapula, and usually that is due to damage to the long thoracic nerve. Now we mentioned about long thoracic nerve, it's coming from C5, C6 and C7 roots, long thoracic nerve. So if that gets damaged, you get paralysis of serratus anterior muscle and wing scapula. Okay. So you can be given these pictures. This picture, of course, you cannot recognize, might not be able to recognize in the exam, but this is a very famous picture that we give for spot exams. Okay, then we can ask, name this condition. What is the muscle paralyzed? What is the nerve affected? Okay, so simple, straightforward answers. Okay. Then a theory part here. You have seen the clavicle. You have seen the clavicle. Now, there are many structures attached to the clavicle or related to the clavicle. Okay, you call it collarbone in English. Now, for that reason, you need to know about the attachments of the clavicle. So by knowing that, you will remember many other things. It's the same with the first rib. Since you have not studied the first rib, we will not talk about it. But when you do the thorax and abdomen module, and when you do the rib cage, remember that you have to pay more attention to the first rib than any other rib. Okay, because there are many structures related to the first rib, and many structures attached to the first rib. Okay. So now in this, now first understand the picture. Now this is the superior view. This is the superior view of the clavicle, and this is the inferior view of the clavicle. Now, when I show you the attachments, some muscle attachments, if they are attached anteriorly or posteriorly, you will see them in both views, not only in one view. But if they are attached to the superior surface, you will only see them in the superior view. If they are attached to the inferior surface, you will only see them in the inferior view. Now, okay, now these are the muscle attachments. Now, to the superior surface, medial end, sternocleidomastoid muscle is attached. Okay, sternocleidomastoid muscle is attached, which is supplied by the accessory nerve. I mentioned it a moment ago. Then pectoralis major muscle, which you have seen in your dissection videos, it is attached to the anterior surface, medial 2/3 of the anterior surface. You can see it in both views. Then the lateral 1/3, you get the deltoid muscle attached. These are called anterior fibers of the deltoid muscle. Then posteriorly and laterally, lateral third, posteriorly, it's the trapezius that is attached. Then to the superior surface, you can see the superior surface, there is a fascia attached, which you have not learned yet. You will only learn it when you do the neck region, which is called the investing layer of deep cervical fascia. Okay, investing layer of deep cervical fascia. You don't have to know it now. Okay, and the important thing is that this fascia encircles the sternocleidomastoid muscle and the trapezius muscle, as you can see. Okay. Then to the superior surface, medial end, the interclavicular ligament is attached. So that ligament passes from one clavicle to the other clavicle. Then on the inferior surface, you get the subclavius muscle attached, which you have seen again in your dissections. Subclavius muscle. Then the subclavius muscle is also enclosed by a fascia called clavipectoral fascia. Clavipectoral fascia. It's attached around the subclavius and fuses with the periosteum of the. It actually continues as the periosteum of the clavicle. Okay. Then there is an important ligament called this one, costoclavicular ligament. It's attached between the costal cartilage of the first rib and the medial end of the inferior surface of the clavicle. More important ligament is this one. The most important ligament in that area is this one. It's coracoclavicular ligament attached between the coracoid process. It's attached between the coracoid process here. If you take the scapula, this is the coracoid process. This is the spine and the acromion. This is the coracoid process of the scapula. So it's attached between the coracoid process and the undersurface of the clavicle. I don't know, if I place the clavicle like this, you might not be able to see it all. So it's not very clear, in this view. So if I place it like this, so there's a place where the two comes very close to each other. So at that point, the coracoclavicular ligament is attached between the coracoid process of the scapula and the undersurface of the clavicle. Now this coracoclavicular ligament Coracoclavicular ligament has two parts, the trapezoid part and the conoid part. Okay, so you call it trapezoid ligament and conoid ligament. Okay, they are both attached to the coracoid process of the scapula. And this ligament is why it is important. This ligament is stronger than the clavicle itself. Okay, so if there is a force applied to this clavicle, that tend, okay, because of this ligament here, um, it's the clavicle that breaks rather than the ligament. Okay, so we'll discuss that during clavicle fractures. Okay, hope you understood this. So some of the things like investing layer of deep cervical fascia is too early for you. You don't have to remember, but the rest of it you can actually remember because you have seen all these things now. Then that brings us to the fracture of the clavicle. It is the most commonly fractured bone in the body. Okay, it's the most commonly fractured bone in the body, and it is usually due to fall on the shoulder or outstretched hand. Now, most of the fractures of the upper limb, they are mainly due to falling on the outstretched hand. Now, this is what is called falling on the outstretched hand. Okay, when you fall, naturally the hand is stretched, and you try to prevent the fall by keeping the palm of the hand on the ground. Okay, so the whole weight of the body passes through the upper limb, and any of these bones, you can have some carpal bones, forearm bones, humerus here, and even the clavicle. They can break, not the scapula. Scapula cannot break because the weight does not pass through the scapula as such. It's through the clavicle that it passes. So all these places can break because of falling on the outstretched hand. They don't break at the same time. Okay, so one weak place will break at a time usually. Okay, so remember that point. Now then the clavicle also can break due to falling on the outstretched hand, especially in children. Okay, and when it breaks, it commonly breaks. It can break at any place, as you know, shown in this picture. It can break at any place, but the commonest site for break is the junction between the middle and the lateral thirds. Junction between the middle and the lateral thirds. So it's somewhere here. Okay, so it's this one. Okay, so that is just medial to the attachment of the coracoclavicular ligament, just medial to the attachment of the coracoclavicular ligament, for several reasons. One reason is that the ligament itself, coracoclavicular ligament itself, is more stronger than the clavicle. That is one point. Second point is, at this point, this is the weakest point. That is the thinnest part of the clavicle. If you take the clavicle and check, you will see that this area is the most thin area in the clavicle, and the forces transmitted through the upper limb will be transmitted through this acromion and the attachments to the lateral end of the clavicle, and then this whole thing, this whole thing will be pushed up, and it breaks here. Okay, because of the strong ligaments there. Okay. Then once the clavicle is fractured, if you look at this picture, once the clavicle is fractured, what happens is that, now you know that the sternocleidomastoid muscle here is attached to the medial end of the clavicle. It's a very strong muscle. Okay, the moment it breaks at this point, the medial end, okay, medial fragment, you call it medial fragment. Medial fragment is pulled up, as you can see here, pulled up by the action of the sternocleidomastoid. Okay. Then the lateral fragment, now this is the lateral fragment. Lateral fragment is the one that is attached to the upper limb now. Okay. Now, just like the sternocleidomastoid, lateral fragment is attempted to be pulled up by the trapezius muscle, which is here, trapezius. There's an attempt by the trapezius to pull it up, but it fails. Remember this point. In the standing position, the trapezius fails to pull it up. Why? Because the weight of the upper limb is too much. Okay, therefore what happens is the distal fragment drops, as you can see here. Distal fragment drops, creating a gap between the broken ends of the medial and the lateral fragments. Okay, it not only drops the lateral fragment with the upper limb, not only drops, there are very strong adductors of the shoulder, which are mainly the pectoralis major and latissimus dorsi muscles. These strong adductors will adduct or pull the lateral fragment medially in this direction. So ultimately what happens is there will be an overlap between these two fragments. Okay, so the two ends will be lying like this. Okay, lateral fragment above, medial fragment below, and there is an overlap here because of this medial pulling towards the medial direction by the strong adductors. I think that explains. So if somebody asks, you what is the anatomical basis of overlapping of the fractured ends of the clavicle, anatomical basis of overlapping of the fractured ends of the clavicle. Okay, so then what you have to mention is this exactly, you know, what I mentioned, why they overlap. Okay, there are at least 3 points. No, medial end is pulled up, lateral end is pulled down by the weight of the upper limb, and the limb is pulled medially. The lateral fragment with the limb is pulled medially by the strong adductors. Okay, so this is an anatomical basis. Okay. Then shoulder dislocation. Shoulder dislocation. Shoulder is the most frequently dislocated joint in the body, I suppose. Okay, and in 95% of the cases, these figures can change. Okay, about 95% of the cases, it is anterior dislocation. It's anterior dislocation. Okay, so in anterior dislocation, what happens is here is the head in anterior dislocation. Okay, the humerus is like this here. Okay, in anterior dislocation, head lies immediately below the coracoid process. Now the coracoid process of scapula is somewhere here. Okay, head lies here. So that position of the head is called a subcoracoid position, therefore, below the coracoid process. That is one point. Now in your bodies, if you try to feel this area, I'll show you. Not having you physically in a lecture hall is this problem of not having you. So it's somewhere here. If you push this area in your bodies, to living anatomy at least, you know, over online. So you try to push that area, you will be able to feel just below the clavicle. If you push here, you will be able to feel the coracoid process. It's painful to push there because the muscle gets uh, sandwiched between your finger and the coracoid process. You can feel the coracoid process there. Immediately below the coracoid process, you feel some hollow area. Okay, so that is the subcoracoid place. That is the place where the head comes and lies. Okay, because of the pulling action of the muscles. Now, what happens is that usually, the head is pulled down, which is called inferior dislocation, and then it comes out of the glenoid cavity and then pulled up by the action of the muscles to come up to this point. And now that is one way of, you know, dislocating. In certain people, without going down and coming up, it can, you know, break the glenoid labrum and directly go into the anterior position. I have seen articles, you know, on that. But anatomists, you know, how they describe it is that the head dislocates inferiorly because the ligaments and the muscles are weak on the inferior side. You must have learned it. So the muscles and ligaments are weak on that side. Therefore, head dislocates inferiorly and then it's pulled up. Okay. So then I'll show you. Okay, so this rotator cuff. Now you have learned about the rotator cuff muscles by now. So it's subscapularis, then it's supraspinatus, infraspinatus, and teres minor. These four short muscles constitute rotator cuff muscles. They have flat tendons fusing with the scapula, and in the inferior side, you don't have this strengthening, rotator cuff strengthening, and even the other ligaments are absent. Therefore, it can easily dislocate inferiorly. Okay, so that is the principle behind it. Once it dislocates, the muscles will pull it back to lie below the coracoid process here. Okay, so that's the basic thing about it. Then the important thing about the shoulder dislocation here is that when it dislocates, because the axillary nerve is related to the cervical neck, if I draw it, this would be the humerus. Axillary nerve is related here. So it's like this. So when this is pulled down, because of this cocker-like, bend area, axillary nerve can get trapped there, okay, and it can break. When this goes down, axillary nerve can break, and if the axillary nerve breaks, then you know what will happen. You know that it carries C5 and C6. We discussed this in the first two slides. C5 and C6 spinal segments, and it supplies the deltoid here, deltoid and teres minor muscles. Teres minor is not a big problem, but deltoid is an important, very important muscle in the shoulder region. So if the axillary nerve is damaged, you get paralysis of deltoid and teres minor muscles. Deltoid paralysis is very obvious. Okay, so this is the point. Then the other thing is axillary nerve. Axillary nerve has two parts. It has two parts: a cutaneous part, cutaneous branch, cutaneous branch, and a motor branch. Cutaneous branch is the one that supplies, the motor branch is the one that supplies the deltoid muscle and the teres minor muscle. The cutaneous part carrying C5 segment supplies. Now if your deltoid is here like this, now the skin over the deltoid, if you take the skin over the deltoid muscle here, somewhere here, okay, above that it's C4. That is the tip of the shoulder supplied by supraclavicular nerves. Then below that, the skin over the lower half of the deltoid, this is the upper half of the deltoid here, skin over the lower half of the deltoid is supplied by cutaneous branches of the axillary nerve. Therefore, it's not only deltoid paralysis, the muscle paralysis, there is anesthesia or loss of sensation in the skin over the lower half of the deltoid muscle in that area. Okay. It's C5 segment. Okay, remember that point. Then the other point is in shoulder dislocation. Now, if you compare the two sides, you see on this side, the normal side, a very nice contour of the shoulder, very nice shape of the shoulder, rounded shape, because you have the glenoid cavity here, you have the acromion here, you have the head of the humerus here, and covered by the muscle. The moment the head is removed from that position, this angle becomes like acute angle like that, like in this case on the right side. So the moment you see this, if a patient comes to your clinic, wherever, with holding, now this person is holding his right hand with the left hand, normal one, and it's bent. You can see this position, and you see this acute angle at the shoulder. Nice contour is lost. So then you know that the head of the shoulder, the head of the humerus is not there anymore. It's here. Okay, subcoracoid position. So the moment you take an X-ray, you will see the head here. Okay, coracoid process is somewhere here. So this is the subcoracoid position of the head. Your glenoid cavity is there. Okay, either it has directly come there or gone down and come back, as I explained before. So it's not difficult. There are maneuvers to put the shoulder joint back. So you can pull it and put it back. Okay, if you are a trained person, you can pull it. You can put a hand here. Okay, a lever here, pull it down and push it out and put it back. Okay, that's the different thing, but experienced person will do that. But as the basic doctors who are operating there, you should be able to diagnose this. Okay, so these are all clinical points that I am mentioning. Okay, rotator cuff I mentioned, we'll skip it. Then fractures of the humerus. You don't need to know all the fractures and all the details, but the basic things, the important things, we will just glance through. Okay. Surgical neck fractures. Now the main reason for surgical neck fractures is falling on the outstretched hand. Okay, I told you many of the injuries are due to falling on the outstretched hand. Then it can damage the axillary nerve again, just like in shoulder dislocation. When the axillary nerve passes, uh, in relation to the surgical neck of the humerus, which is here, surgical neck of the humerus, behind the posterior, behind the humerus, behind surgical neck of the humerus. The axillary nerve can get damaged. At the same time, there's an artery passing with the nerve, which is called the posterior circumflex humeral artery. It also can get damaged. Now, there will be a bleeding if the posterior circumflex humeral artery is damaged, but that is not a major problem. The major problem again would be the damage to the axillary nerve. Then you know the issues with the axillary nerve damaged. There can be anesthesia over the lower half of the muscle, and you can have paralysis of the deltoid and teres minor muscles. Okay, so the deltoid paralysis, the other clinical other problem you get with the deltoid paralysis is that now when it comes to abduction of the shoulder joint, shoulder abduction, the initial part of abduction is done by the supraspinatus muscle. Now you have the humerus like this. You get the supraspinatus muscle attached like this, supplied by suprascapular nerve. So that one is necessary for the initiation of abduction. So about first 15 degrees of abduction is done by the supraspinatus muscle. Okay. But after the first 15 degrees, the deltoid takes over. Deltoid takes over. Deltoid cannot initiate abduction because it's, when the arm is hanging on the side, the direction of pull is up like that. So it cannot initiate the abduction. You have to have the supraspinatus to initiate abduction. Then the deltoid can take over. So what happens is when the deltoid is paralyzed due to damage to the axillary nerve, there is loss of abduction after the first 15 degrees, not before. Okay. If the supraspinatus is paralyzed due to damage to the suprascapular nerves, then the first 15 degrees abduction is affected, not after that, because the deltoid is intact in that case. Okay, so it's like that. Then you know the deltoid has several parts. The deltoid muscle is something like this. You have an anterior part. There you have a posterior part and an intermediate part. So the anterior part is responsible for flexion and medial rotation to some extent. Then posterior fibers are extensors and lateral rotators, and the intermediate fibers are the abductors. Okay, so other than abduction, flexion, extension, and the rotations are also go on because of anterior and posterior fibers of the deltoid muscle. Then anesthesia over the lower half of the deltoid, we mentioned this. Okay, lower half of the deltoid anesthesia. Then if the humerus is fractured at the shaft, okay, at the shaft is a fairly long area, so it can get damaged at the higher level or fairly lower level or in between. Okay, so there are the muscle action and the position of the fragments, broken fragments are different. I am not going into details of that too much for you. Only the important thing is if there is a shaft fracture at your level, the important thing to remember is that you get the radial groove in that area behind the shaft of the humerus, So the radial nerve and the deep artery of the arm are there. So the radial nerve and deep artery of the arm or profunda brachii artery, they can get damaged. Arterial damage is not the main issue. Again, it's the radial nerve damage that is important. So if the radial nerves, there are two things. Either the radial nerve can get damaged due to the injury itself, because the ragged ends, the ends are ragged. These ends can damage the radial nerve. Then the effect of radial nerve damage would be immediate, because immediately after the injury, you get the loss of nerve function. But then there's another phenomenon. You might not damage the radial nerve immediately. You will fracture the bone. Radial nerve will be there without getting damaged. But later on, after a few weeks, when the fracture is repaired by the formation of bone there, which is called callus, formation of callus, which you can see here, formation of callus. Here, you can faintly see the formation of callus there. This whole area is callus formation. Now the nerve can get entrapped. You call it entrapment. nerve can get entrapped in the newly formed callus. If the nerve gets entrapped there in the callus, again, the nerve can get compressed and you can develop a radial nerve palsy. Okay, so but that will take time. It's not immediate. Okay, so based on how the patients complain, whether it's immediately after the injury or whether it develops over a period of time, then you can easily think of this. If the nerve is entrapped in the callus, you might have to do a surgery and release it. Okay, remember both points. Then the outcome of radial nerve damage. Outcome of radial nerve damage here is that radial nerve it not only supplies the triceps muscle here, triceps muscle, it also supplies all extensor muscles of the forearm. Extensor muscles of the forearm, they are the wrist extensors. So all the wrist extensors are gone. Therefore, the person cannot extend the wrist. It's flexed because of the unopposed action of flexors here. You get the flexor muscles. The flexors are very strong. Flexor muscles are supplied by the median nerve and ulnar nerve. They are unaffected in this case. Therefore, due to the action of flexor muscles, the wrist is not only that you cannot extend it, it's kept flexed. Okay, which is called wrist drop. This is called wrist drop. Wrist drop. Okay, remember this point. But on the other hand, extension of the elbow joint done by the trapezius, is not much affected because the trapezius is supplied at a little higher level. You can actually see the trapezius supply here. You can see the trapezius supply there. Now the injury is somewhere here in shaft. Therefore, the trapezius supply is not affected. So you can extend the elbow joint, but the extension of the wrist is affected. Okay, extension of the wrist is affected. Remember this point. Then the other point is now the radial nerve, after passing through the radial groove at the elbow joint, the radial nerve divides into two branches. If the radial nerve comes like this at the elbow joint, it divides into a deep branch and a superficial branch. Okay, so the deep branch of the radial nerve is called posterior interosseous nerve, which is the nerve of the muscles of the posterior or the extensor compartment of the forearm. Then the superficial branch of the radial nerve is a purely cutaneous nerve. It's a sensory nerve that supplies the posterior aspect of the forearm, skin over the posterior aspect of the forearm, and the skin over the lateral aspect of the hand. So that area, this whole area is supplied by that nerve. But I told you, if that nerve is damaged because of the overlap by the ulnar and median nerves, you might get a very small area of anesthesia sometimes over the anatomical snuff box. Okay, I told you. Then the supracondylar fractures, another important fracture. You can see the elbow joint here in this X-ray. This is the distal end of the humerus. This is the proximal end of the ulna and the proximal end of the radius here. Now the fracture is at the supracondylar lines. Now in the humerus, you know, the humerus comes down like this and expands like that to produce the olecranon and the medial and lateral epicondyles. These are called supracondylar ridges at the distal end. Fracture is through that area. That's why you call it supracondylar fracture. Okay. Now the supracondylar fractures again, very commonly it is due to falling on the outstretched hand. But then, you know, if the elbow is slightly bent, when falling on the outstretched hand, the force is directed in that way, and this part breaks and pushed backwards. So you can see it very clearly here. The force has been applied like this. Distal end of the humerus has been fractured, and the fractured fragment is pushed backwards. It's displaced. We call it displacement. Displaced and angulated posteriorly. In 95% of the cases, it's like this. You don't have to know these percentages and all. But there's another way of fracturing the, getting the same fracture, supracondylar fracture. Now in this case, it's not the same picture. Now it's angulated anteriorly, maybe pushed anteriorly also. But again, it's a supracondylar fracture. Now, if you think of this, what has happened is the person has fallen on the flexed elbow. Okay, not on the outstretched hand. If you fall on the flexed elbow, then the direction would be in that way. So this part breaks and directed anteriorly. It's a rare thing. Okay, common thing is this other phenomenon. You don't have to know, these different things. Just know supracondylar fracture. Where you fracture when you say supracondylar fracture. The important thing is the structures that are damaged due to this. Okay, so that is the part that is frequently asked from you. Okay, so if you just know what is supracondylar fracture, that's enough. If you know the remaining part, you know that many structures are passing from the arm to the forearm in that area. You get the median nerve passing here. You get the ulnar nerve passing behind. You get the brachial artery coming down here. And you get the median nerve dividing into anterior introsis and posterior anterior introsis branch here. Giving the anterior introsis branch, posterior introsis is from the radial nerve. So all these structures can get, even the radial nerve, okay, even the radial nerve coming from behind can get damaged, okay, because of supracondylar fractures. The ragged bone edge, you can see the ragged edge here. These ragged bone edges, especially this one, can damage the structures passing in that area, okay. So as I mentioned, damage to all these things can happen, okay. And the brachial artery also can get damaged. It can either get damaged or it can get compressed. It can get compressed because of this displacement of bony fragments. Okay. Then there's another point, important point. I'll come back to damage to the brachial artery again. There's another picture coming up here. Before that, I'll show you something else. I'll remove the video again. Okay. Now, if you bend your elbow, you can check these things while you are listening to the lecture. If you bend your elbow to 90 degrees, okay, 90 degrees elbow, you can feel with the other hand, with the thumb, middle finger, and the index finger. You can put your index finger to this point, okay. Then you can put your thumb to one of these things and the middle finger, okay. Middle finger to the other one. You can do that, okay. So if you put these three fingers, thumb, index finger, and middle fingers to these three bony points, medial epicondyle, lateral epicondyle of the humerus, and the olecranon of the ulna. If you put these fingers to the three bony points, you will see that there is a triangular shape. So the triangular shape, you can see the triangular shape here. Now in supracondylar fractures, since the fracture line passes somewhere there, if you check in the patient, this triangular arrangement has not affected. Okay, triangular arrangement has not affected. Then, on the other hand, even though the elbow is not a very common joint to dislocate, it's a very strong joint with a good stability, but it can get dislocated. But if the elbow joint is dislocated, then the relative position of the olecranon in relation to the medial and lateral epicondyles of the humerus is changed. It might go up here or somewhere. And this triangular arrangement is disturbed. So even without an X-ray, it's easy to figure out whether it's a supracondylar fracture or elbow dislocation. In elbow dislocation, this triangular arrangement of the three bony points will be disturbed. Okay, so this also can be checked in exams. Okay, because these are clinical findings. Okay. Then this other point. If the brachial artery is damaged or compressed, and if there's lack of blood supply to the distal part of the arm, so if the artery is affected here, then its branches, the radial artery and ulnar artery and the introosseous artery, there's another one called introosseous artery supplying the extensor part. All these arteries are branches of the brachial artery. So it's the main artery that supplies the forearm and the hand. So if the brachial artery is either damaged or compressed, then if that was not detected by the doctor, okay, that's why we teach you all these things. So even the junior doctors should be able to diagnose these cases. Otherwise, if you miss it, and if you don't attend to it immediately, you don't repair the artery or relieve the block immediately, what will happen is after a few hours or even few days, you will get the muscles in the forearm. The muscles die, you call them necrosis. Death is called necrosis. And after they die, their tissues are replaced by collagen fibers. You call it fibrosis. Okay. When the muscles get fibrosed, they become tough and they get, sort of contracted like. Okay. Now what happens is, uh, so if this happens, the condition that you get is called Walkman's ischemic contracture. Okay, ischemic means lack of blood supply. Contracture means what I just said. When the muscles get fibrosed, they get shortened. Okay, so then accordingly, the joints will be deformed. Joints will be deformed. Now here it's interesting. If you look at this hand, you see that the wrist is fully flexed here. Wrist is fully flexed. The interphalangeal joints are flexed. Interphalangeal joints are flexed. The metacarpophalangeal joints here are extended. Metacarpophalangeal joints are extended. So it's wrist flexion, interphalangeal joint flexion, and metacarpophalangeal joint extension. Okay. Why this happens is that in this case, in this particular example, the damage to the brachial artery is such that both flexors and extensors were affected equally. They have been affected equally. They are all dead and fibrosed. Okay. And in general, flexors are more stronger, more bulkier and stronger than extensors. When you dissect if you find time to dissect later on, if you come to the dissecting room, look for this. Okay, you will see that the flexor side is more bulky and stronger than the extensor side. So if they are all fibrosed, both sides, anyway, the effect of flexors is more than the fibrosed effect of flexors is more than the extensors. So what happens is that the flexors will fully flex the wrist joint, fully flex. Not only that, the long flexors like flexor digitorum profundus and superficialis will flex the interphalangeal joints also here. Okay. But the extensors, they also will do something, but the only thing they can do is to extend the metacarpophalangeal joints. That's why you get this picture. Okay. Now, if you just look at only this part of the hand, forgetting the wrist joint area, this is actually like a claw hand. This is called a claw hand. It's a full claw hand. You will see different types of claw hands. Ulna claw hand. Then this is full claw hand. Ulna claw hand is a half claw hand. Okay. So this is a claw hand. Claw hand is something like this. Okay. Claw hand is something like this. Okay, I don't know whether you can see it. Okay. So it's flexion of the interphalangeal joints and extension of metacarpophalangeal joints here. Okay. So it's very difficult to show these things. Okay. Then, now this is the typical example where both flexors and extensors are damaged equally. But it will not happen like that because the injury to the brachial artery might not be the same all the time. In different people, the degree of damage can be different. Therefore, there can be varying degrees of damage to extensors and flexors. If they are not fully damaged, okay, then the deformity also may vary. You might not get exactly this deformity, but a different. You might get less flexion of the wrist joint, less flexion of the interphalangeal joints, whatever. Okay. Then the fractures of the distal end of the forearm bones. Distal end of the forearm bones. What are forearm bones? It's the radius and ulna. Okay. So if you fracture the radius and ulna, one of them, especially the radius rather than the ulna, you call them fractures of the distal end of the forearm bones. Okay. Now, typical example for fractures of the distal end of the forearm bones is Colles fracture. Okay, this is called Colles fracture. So you can see Colles fracture here. In this case, both bones are fractured. Both bones, distal end of the radius and ulna, both are fractured. This happens usually in the old age, after 50s. After 50s, when the bones become weaker, both males and females, you can get these Colles fractures due to weakening of the bones. Again, if you fall on the outstretched hand. Okay, if you fall on the outstretched hand. And the distal fragment, you can see now, this is the normal direction of the bone. Distal fragment has been pushed backwards and angulated posteriorly. Okay. And this deformity is called dinner fork deformity. It's called dinner fork deformity. Why? If you ask the person to keep the forearm and the hand on a flat surface like table, as you see in this case, you see this, it's the shape of a dinner fork. Okay, so the dinner fork is that shape. Okay, so it comes like this and like this. Okay, that is called dinner fork deformity. Okay, so if you don't correct it, it limits the flexion. Then there's an interesting thing, reverse. This reverse of Colles fracture can happen. Now Colles fracture is falling due to falling on the outstretched hand on the palm side of the hand. Now reverse Colles fracture is when you fall on the dorsum of the hand. Now here this is Colles fracture. This is reverse Colles fracture. When you fall on the dorsum of the hand, then the fractured fragment will be directed anteriorly. Okay. Again, that is in the old age. The same thing. Old age people can get that one. Okay. Now this is also called Smith's fracture. Reverse Colles fracture is also called Smith's fracture. Okay. Uh, so that's something that you have to remember. Now, because of this Colles fracture and Smith's fracture, even though you get radial artery, ulnar artery, and median nerve, ulnar nerve passing in that area, usually these structures don't get damaged. Okay, don't go home with the idea that these things can get damaged. Okay, usually you don't see. You see a lot of Colles fractures when you go to wards, but in either of these Smith's fracture and Colles fracture, you usually don't see, if I know it correctly, usually don't see damage to neurovascular structures. Okay. Then the scaphoid fracture. Now, scaphoid is a carpal bone. It's the most medial carpal bone in the first row of carpal bones. There are two rows of carpal bones, four here, carpal bones. Now, scaphoid is the medial end carpal bone, and the lunate is next. These two, they articulate with the radius. Okay, so this is the radius, this is the scaphoid, and this is the lunate. Okay, uh, now the scaphoid, since it articulates with the head of the radius, uh, when you fall on the outstretched hand, especially, forces that are transmitted through the palm are transmitted through the scaphoid and lunate. Scaphoid can fracture because it gets trapped between the distal end of the radius, distal end of the radius, not head, okay, distal end of the radius and the rest of the bones here. So if the scaphoid fractures, the issue is it's one thing is it's involved with the joint here. So if there's a fracture line, you can get later you can get osteoarthritis and all. But the most important point is not that. One important point is that uh, say you fall on the outstretched hand, you get a clavicular fracture, or you get a fracture of the shaft of the humerus, or even Colles fracture. So anything can fracture when you fall on the outstretched hand. You might miss, because you see the big fracture, you might miss the scaphoid fracture here if you don't look for it specifically. Now, as doctors, you should know that if you have other fractures due to falling on the outstretched hand, like the fractures I mentioned, you should specifically look for a scaphoid fracture. How you do that? You press the anatomical snuff box. Now, you remember anatomical snuff box? It's something like this behind the thumb. Anatomical snuff box is a triangular area. So you get different borders, tendons of muscles forming lateral and medial borders. Flow is formed by four bones. Now the four bones are the distal end of the radius here, scaphoid, then you get the trapezium and the base of the first metacarpal bone. Okay, distal end of the radius, scaphoid, trapezium, and the base of the thumb metacarpal. So these are the bones that contribute to form the flow of the anatomical snuff box. Now, if you put your finger here and press here, anatomical snuff box, the person will be in severe pain. You call it tenderness. There will be severe tenderness if you press the flow of the anatomical snuff box if there is a scaphoid fracture. Okay, so then by that you can detect it. That's one way of detecting. Then you do an X-ray of the wrist. Then you will be able to detect this. This is an X-ray. Okay, you will be able to detect the fracture of the scaphoid. If there is a fracture of the scaphoid, you have to send the person to an orthopedic surgeon to splint it, to correct it, whatever they do. Okay. Why you have to do that? Because the scaphoid is peculiar that it gets its blood supply not from this end, not from the proximal end, but from the distal end. Okay. So the blood supply to the scaphoid comes from the distal side and going like this. Okay. Therefore, if you fracture the bone somewhere here, okay, then this part, the proximal fragment, will not get its blood supply and it will undergo necrosis, death. This part will be okay because it gets blood supply. The proximal fragment will get affected, it will die, and when it dies, it is involved with the joint here. You will get all sorts of problems. Okay, so you will have to correct it immediately. You detect it and correct it. Okay, you cannot miss it as a doctor. Okay, so we ask questions. Okay, so we ask questions about the scaphoid fractures. Not many details. We will ask. We will check whether you know about the scaphoid fractures, its importance, and why the bone why the bone gets necrosed, dies. Okay, and always you have to say it's not the distal fragment but the proximal fragment that dies off. Okay, so you should be able to answer the anatomical basis again. Anatomical basis is the distal blood supply. Okay. Okay, this is how it is supplied. Again, there can be variations of supply. Some will be supplied somewhere here also. So even the fracture here will spare the proximal fragment. But if the supply is very distal, like in this case, even a fracture somewhere here will destroy this part, lack of blood supply. Okay. Now in this case, for instance, here you get a very long blood supply. Okay, only a fracture here will destroy this part. Okay, rest of the fractures will even a fracture here will destroy, because this blood vessels will stop. Yeah. So then remember this point. It's a point that you need to remember. In compartment syndrome of the forearm, compartment syndrome. Now we learned so far. You have learned that you have learned the upper limb and partly you have learned the lower limb also. Now if you take this is the bone of the limb and the limb is surrounded by deep fascia. It's fairly tough fascia. And when there are compartments, they are separated by intermuscular septa. Intermuscular septa. And these intermuscular septa continue as deep fascia and as the periosteum of the bone also. So these are firm attachments. To separate these, you have to tear them. Okay. So if the pressure develops in one of these compartments, either due to swelling of the muscle, say you get a snake bite, or you get a trap gun injury, and there is swelling of the muscles inside. Then, since this is a closed space, pressure increases. Pressure increases in this closed space, and when the pressure increases, you get blood vessels inside. You get veins, arteries, and nerves. Those are the important ones that you get there. No? Veins collapse first, then the arteries collapse. Nerves get affected last. Okay, because of the collapse of arteries, especially the pressure. Because of the pressure, when the arteries collapse, blood supply to the distal end of the limb. Okay, if the limb is like this. Okay, if this happens somewhere here, compartment syndrome, the blood supply to the distal end will get affected, and the distal part of the limb dies off. Okay, like in Walkman's ischemic contracture, compartment syndrome also can damage the distal part of the limb. The only thing you can do here, the simple thing is to relieve the pressure. Relieve the pressure. To relieve the pressure, what you do is you do this. You can see the degree of cut here. So this is, they have cut like zigzag. This is to relieve all the compartments of the pressure. And this, even though it's a very big cut, you can save the hand by releasing the pressure. Okay, they have only cut the fascia here, the deep fascia and the intermuscular septa. Okay. Now in compartment syndrome, you might not need to know all these things, but I'll just mention the pain. Pain is disproportionate to the injury. Injury might be small, maybe some insect bite or small, small snake bite. But the pain would be very serious. Pain would be very severe. Okay, and then if you try to stretch joints, stretch muscles passively, then the pain would increase. Okay, and there's lack of capillary feeling. What is capillary feeling is, you get your fingers, you press it like this for few seconds, keep it pressed, then you will see that usually the fingers are pink colored. You press it, it becomes white because all the blood in the capillaries will be uh, pushed out. Then the moment you release it, it gets refilled within seconds. Okay, it gets refilled within seconds. But if there is an obstruction to the blood supply, it will take several seconds, more than 15 seconds to something to fill like that. That is called delayed capillary filling. Okay, so these are all features of compartment syndrome, but you don't have to know all this, to that extent. Okay. Okay, then these two conditions, tennis elbow and golfer's elbow. Now, tennis elbow is due to overuse of extensor muscles. Now, you know that there is a common flexor origin and common extensor origin. Common extensor origin is at the lateral epicondyle. This is the lateral epicondyle of the humerus, sorry. Lateral epicondyle of the humerus. That is tennis elbow, overuse of the extensor muscles. Then the overuse of the flexor muscles is at the pain is at the common flexor origin. Okay. Now a good example for tennis elbow is the tennis elbow is tennis players. Okay, tennis players, tennis racket is heavier than the badminton racket or the table tennis racket. So when you extend the wrist to bring the racket back to its position before you hit, okay, that causes extensors to be overused. Okay, that's why they get this condition. You get swelling and redness and pain in that area because all the muscles take origin from one place. So actually, you can give certain injections to that area and relieve that pain. Then similarly, golf players, they use their plexus. Okay, when they're hitting the ball, flexes too much, so you get the golfer's elbow. Now you see these conditions in our people, even though especially in housewives, you get tennis elbow and golfer's elbow, not because they play tennis or golf, when the husbands are not at home. They do household work like sweeping and other heavy work. Because of that, you get overuse of extensor muscles and flexor muscles, and they get these conditions. Okay, so that's it. Then brachial plexus injuries. Again, you can get different types of brachial plexus injuries. Now, if you do neck surgeries and you do certain errors in neck surgeries, you can damage any part of brachial plexus. Okay, here we are not going into the details of all that. We are taking two examples where the brachial plexus, parts of brachial plexus can get damaged, especially the nerve roots of brachial plexus. There are two important conditions called, one is Erb Duchenne palsy. Erb Duchenne palsy. Sometimes you call it Erb's palsy. Okay, Erb's palsy or Erb Duchenne palsy. Now, in Erb Duchenne palsy, what happens is that there's traction of C5 and C6 nerve roots. There's traction of C5 and C6 on C5 and C6 nerve roots. Now, these are the upper two nerve roots of the brachial plexus. Now, what happens is that now if you fall like this from a height, you fall in such a way that the neck, the head and the neck and the shoulders get apart, they are pulled apart, and that applies a lot of stress on the upper nerve roots. Then the same thing can happen during delivery. Now in this case, this baby is during delivery, there is a delay in delivery, must have been a delay in delivery. So the doctor or somebody tries to pull the head out. If the shoulders are stuck inside, when the baby's head is pulled out, again the same thing that happened here can happen to this child. So you can get even bilateral upper nerve root damage, C5 and C6 nerve root damage, not only one side, on both sides. Now in this case, at least it's one side. Okay, so you can get bilateral Erb Duchenne palsy, which is a very serious condition. Okay, very serious condition, because if it's a severe damage, it might not be able to. I don't know whether they can correct it. They might be able to correct it now. Not very sure about it. Okay, anyway, it's a very serious damage. Now, what happens is that, now we mentioned in the first few slides that all these nerves, axillary nerve, subscapular nerves, and suprascapular nerves, they carry C5 and C6 segments. So all these nerves will be affected if the first nerve roots are damaged. So that you get paralysis of all these muscles, supraspinatus, infraspinatus, then other shoulder muscles like subscapularis and all that. Okay, and even the deltoid is paralyzed. Now, even the biceps muscles, because the anterior compartment of the arm is C5 and C6. Okay, biceps and brachialis muscles, they are also paralyzed. So then you should be able to describe the deformity anatomically. Now, what is the deformity? Now, this is the deformity you get. Arm hangs by the side of the trunk. Okay, it's medially, it's hangs by the side means adducted. Okay, adducted, medially rotated. Okay, adducted, medially rotated, and it is pronated. It is pronated. Okay, so this is pronated. I don't know which side I should. It's pronated so that the palm faces backwards. Okay, palm faces backwards. It's like a waiter asking for a tip. Okay, without getting noticed by the manager. Okay, so a waiter asking for a tip. Now, therefore, it is called waiter's tip position. All these, Englishman's terms. Okay, our waiters, they don't ask for the tip like that. Okay, but anyway, you call it waiter's tip position. But remember this position. There's an anatomical basis for this position. Now, the deltoid is paralyzed here. Deltoid is paralyzed. Even the supraspinatus is paralyzed. Therefore, abduction is totally gone. Okay. Now, what are the strong adductors? You get the pec major here. You get the latissimus dorsi from other side, from the back side. These are strong adductors. They are intact. Okay. They are supplied by not C5 and C6, but C7, C8 like. Okay. So then they are intact. So they adduct the arm. That's why you get the arm adducted. Okay. Then elbow extended. I didn't mention elbow fully extended. Why? Because the biceps and brachialis are paralyzed, but the triceps is intact. Triceps is C7, C8. Okay, triceps is, so the elbow is extended. Then now the deltoid here, the posterior fibers of deltoid and the infraspinatus, they are all external rotators of the shoulder joint. Now they are gone now. Deltoid here, the pec major here, pectoralis major is a strong medial rotator. So that medially rotates the shoulder joint. Okay. Then the other thing is biceps. Both biceps and supinator, they are supplied by C6 segment for supination of the forearm, that is here. So supination is C6, pronation is C7 and C8. Okay. So pronator contractors and pronator teres are not affected. So there is pronation of the forearm. Okay. So this is the anatomical basis of this deformity in Erb Duchenne type of palsy. Okay. So we have asked this question several times to describe the anatomical basis of this position. Okay. Then the other side of the brachial plexus can get damaged, quite opposite to the Erb Duchenne palsy. In Klumpke's palsy, what you call Klumpke's palsy, the lower nerve roots can get damaged. It's C8 and T1 nerve roots. C8 and T1 nerve roots can get damaged. Now, the reason could be this. Now, you can see here, a person is falling from a height. On the way he gets hold of something. Okay, so you can imagine the speed of a person coming down with the weight of the body. Okay, weight of the body. Suddenly, if it hangs onto something, you will get a sudden jerk in that area. So the lower roots of brachial plexus can get stretched and they can get damaged. Same thing can happen. Now here the baby is delivered. Now this is a breech delivery. So back comes first, and the baby gets stuck inside. Someone is pulling from the back. Okay, so the shoulders are inside. The same thing that happened here can happen to the baby. One-sided or both sides, lower nerve roots can get damaged. So this is called Klumpke's palsy. Now C8 and T1 nerve roots, they actually supply the intrinsic muscles of the hand. Intrinsic muscles of the hand. Okay, so your interossei, lumbricals, and even thenar and hypothenar muscles all are supplied by C8 and T1 roots. Okay, and therefore all these muscles will be paralyzed, and action of these small muscles, especially lumbricals and interossei, are to oppose the action of long flexors and extensors of the forearm. So when both actions are gone, then just like in the Walkman's ischemic contract, even though the mechanism is different, you get unopposed action of flexors and extensors. What will happen is that you don't get any features of the wrist here, but you get flexion of interphalangeal joints and extension of metacarpophalangeal joints. Flexion of interphalangeal joints is due to the action of flexors, and flexion of metacarpophalangeal, extension of metacarpophalangeal joints is due to the action of extensors. Okay, so this is called full claw hand. Full claw hand. Sometimes you can get Horner's syndrome in these patients. You don't know about Horner's syndrome. It's too early for you to know about the Horner's syndrome. Okay, so just drop it for the moment. Later on, you will revisit it. Not now. Okay. Then the cervical rib. Cervical rib. Cervical rib is a rib. The ribs are in the thoracic region from T1 to T8. Now, a cervical rib is a rib attached, a very small rib attached to the 7th cervical vertebra, which is the lower part of the neck. And such a rib, it is not, it's a very short rib, as you can see here. There is a fibrous band usually attaching it to the superior surface of the first rib. Now, this is the first rib, superior surface of the first rib. And because of this attachment, the structures passing over the superior surface of the first rib, like the subclavian artery, and more importantly, the lower root of brachial plexus passing here, can get compressed. Okay, can get compressed, and that compression, that can here T1 nerve root, brachial plexus can get compressed, and that this thoracic outlet syndrome, again you will learn later. Okay, not now. Okay, when you do the thorax, you will learn it. Thoracic outlet is that area. So because you will get compression of these structures, you might get problems with blood supply to the upper limb. You get pain radiating on the medial aspect of the arm because that is the dermatomal supply by T1. And if you don't correct it, then you get more serious complications. But usually they are coming with pain, complaining of pain radiating on the medial aspect of the forearm line. Okay, so here is how the structures are related to the superior surface of the first rib. So this band, fibrous band, we will be discussing the flexor and extensor reticula now. The flexor retinaculum, it's on the anterior aspect of the wrist here, flexor retinaculum, and that prevents jutting out of tendons, long flexor tendons, when you flex the wrist as well as the fingers. Otherwise, the tendons will jut out. They will come out if you don't have something to keep it in place. So that is basically the meaning of having a flexor retinaculum. Now the flexor retinaculum, as you can see here, is attached to 4 of the 8 carpal bones. Now you have on the lateral side, this is the radial side, you have the tubercle of the scaphoid and the ridge of the trapezium to which it is attached. Then on the medial side, this side, there is the hook of the hamate and the pisiform to which it is attached. So there are 2 bones from the proximal row and 2 bones from the distal row. So then if you take a look at the extensor retinaculum, on the other hand, extensor retinaculum is attached to the distal end of the radius here, that is here, distal end of the radius laterally, and medially it is attached to the pisiform and the triquetral bones. Pisiform and the triquetral bone. Basically, the medial attachment of both flexor and extensor reticula are almost the same, except for the hook of the hamate there. Then the lateral attachment is the difference. Flexor retinaculum is clinically more important than the extensor retinaculum. Of course, the function is the same. Extensor retinaculum also prevents jutting out of tendons when you extend the wrist joint and the fingers. So that is the same. But from a clinical point of view, flexor retinaculum is more important than the extensor retinaculum, because structures underneath the flexor retinaculum can get compressed. We will discuss it in a moment. And then surgeons will have to cut the flexor retinaculum in the middle and release tension inside underneath it to relieve the symptoms of when the structures get compressed underneath it. So we'll discuss these things. Then the other point is the flexor retinaculum has there are two important tunnels created within the flexor retinaculum. One is on the lateral side, that is for the tendon of the flexor carpi radialis tendon. Then there's another one on the medial side, that is for the ulnar neurovascular bundle, ulnar artery and the ulnar nerve mainly, and that one is called Guyon's canal. Guyon's canal, clinically important because the ulnar nerve can get entrapped, can get compressed and entrapped in that canal, Guyon's canal. So if that happens, then the structures, the intrinsic muscles of the hand supplied by the ulnar nerve will be paralyzed, or at least they will be weak. So this is this tunnel inside the flexor retinaculum for the flexor carpi radialis tendon that I mentioned just now. Then the Guyon's canal would be somewhere here. If you it's split like that, you will have better diagrams to show that. This one does not show it. Okay. Anyway, now the more important point is the main tunnel that is there, which is the carpal tunnel. Okay. Now carpal tunnel is a fibro-osseous tunnel. Why I call it fibro-osseous? On one side you get the flexor retinaculum, which is very tough fibrous tissue. Then on the other side you get the carpal bones. It's both carpal, the rows of carpal bones. It could be either the proximal row or the distal row of carpal bones. Wherever you cut, if you cut at the distal row, then you will get the distal carpal bones. If you cut at the proximal row, then you will see the proximal row of bones. Here it's mainly the proximal row that they have cut through. That's why you see this tubercle of scaphoid, scaphoid, triquetral, and lunate. This is the proximal row of bones. You can cut at the distal row also. That's what I meant. Okay, so if you ask to draw a cross section, so as carpal bones, you can have either of the two rows. Okay, there's no problem. Then this is called fibro-osseous because bone on that side and fibrous tissue on this side. Okay, that's why you call it fibro-osseous tunnel. Then now, if the pressure inside this tunnel increases for some reason, in certain conditions, the pressure inside the tunnel can increase. Then the structures inside the tunnel can get compressed. Now, what are the structures inside the tunnel? What are the structures outside the tunnel? Now, you can see an important structure here, the median nerve, passes through the tunnel. So that is one structure that can get compressed if the pressure inside the carpal tunnel increases. So that is one thing. Then you can see the ulnar nerve and ulnar artery, mainly the ulnar nerve we are concerned about here, that passes superficial to the flexor retinaculum. It's not inside the carpal tunnel. Therefore, even if the pressure inside the carpal tunnel goes up, ulnar nerve is spared. Then there's another nerve. It is a branch of the median nerve. It is called Palma branch of the median nerve. Sometimes we call it Palma cutaneous branch of the median nerve. Now that one is a branch of the median nerve. It's given proximal to the flexor retinaculum. If the flexor retinaculum is like this, median nerve comes like this and passes underneath the flexor retinaculum to enter the hand. The Palma branch of the median nerve is given just before the flexor retinaculum and it passes superficial to the flexor retinaculum. So that's another nerve that is not getting compressed if the pressure inside the carpal tunnel increases. Now, this pressure increase in the carpal tunnel is called carpal tunnel syndrome. Carpal tunnel syndrome. And even though the tendons are there inside that, they don't get affected, because before that you get the nerves affected and patients come to you for treatment. Okay, tendons are tough tissues. Okay, they don't have any big effect when the pressure goes up. So this is the basic problem here in carpal tunnel syndrome. Then this is the clinical picture of carpal tunnel syndrome. Now, by now you should know that even we discussed here, lateral 3.5 fingers, we are referring to the cutaneous supply, the sensory supply. Lateral 3.5 fingers and that part of the hand, including the thumb, are supplied by the median nerve. After passing underneath the through the carpal tunnel, underneath the flexor retinaculum. So what happens is that when the nerve gets compressed here, then this area, lateral 3.5 fingers, there is a sensory effect. So sensations are either diminished, or if the condition is severe, sensations would be lost. So that's one point. Then the second point is, as we said in the previous slide, the Palma branch of the median nerve, which passes superficial to the flexor retinaculum, supplies the skin over the thenar eminence. You know what is thenar eminence and hypothenar eminence? You get hypothenar eminence here and thenar eminence there. Now the skin over the thenar eminence is supplied by the Palma branch of the median nerve, which is spared, which is not affected in carpal tunnel syndrome. Therefore, even though we say that there is a sensory loss on the lateral side of the hand, lateral 3.5 fingers and the palm, this area is spared. Okay, skin over the thenar eminence is not affected. The sensory is normal in that area. Okay, so these points you have to remember with reasons. Number one. Number two, the median nerve, after passing through the carpal tunnel and entering the palm, it gives a recurrent motor branch to the thenar muscles. So you know the thenar muscles, you get flexor pollicis brevis, opponens pollicis, and so on. This and abductor pollicis brevis. These muscles are supplied by this recurrent motor branch of the median nerve. Then you get these cutaneous branches, which are digital nerves. They supply the skin of the palm and the fingers, 3.5 fingers. So they are affected. That's why you get the sensory loss here. Okay, we already discussed it. Then other than the sensory loss, because of the palma, the recurrent motor branch is affected, the muscles of the thenar eminence are either weak or they are not paralyzed as such, but they become weak, and then they become smaller and smaller because of lack of nerve supply, which is called atrophy. Okay, this you learn when you do pathology. Okay, so the muscles in the thenar eminence gets atrophied. So the thenar eminence, the prominence disappears gradually. Okay, it becomes flat. Okay, so on the other hand, if it comes to the movement of the fingers are moved. It's true that the fingers get fingers are controlled by interosseous and lumbricals, but the nerve supply for the movement of fingers is mainly here, because the long flexors are supplied in the forearm. Their tendons only come into the hand. So the fingers can be flexed without a problem. Okay, so there is no problem with the finger flexion here. It's mainly the sensory here, and it's mainly the movements are okay here. Okay, sensory affected. The muscles are atrophied here, but the sensory is okay. Okay, so that's how it happens. Okay, it's not difficult to remember. Then a few points about the palm. Now, in the palm, there is what is called Palma Aponeurosis. Palma Aponeurosis, which is an expansion of the palmaris longus tendon of the palmaris longus muscle, which is insignificant muscle. It's not a very important muscle, but this Palma Aponeurosis is in a way important, because this Palma Aponeurosis, it sends two fibrous septa, one from its lateral border, this border, and the other one is from this border, medial border, two fibrous septa are sent in. And these two fibrous septa, they get attached to the third metacarpal bone, which is indicated by this red dotted line, third metacarpal bone. That is the metacarpal bone of the middle finger, and the fifth metacarpal bone. This is the fifth metacarpal bone. This is the third metacarpal bone. Now, third metacarpal bone is the metacarpal bone of the little finger. Now, this is called the fibrous septum, originating from the lateral border of the aponeurosis, Palma Aponeurosis, is called the lateral septum because this is the lateral side and this is the medial side. Okay, so if you look at this, you can see that it runs at an angle. Okay, it's obliquely running to get attached to the third metacarpal bone. Then you get the medial septum getting attached to the fifth metacarpal bone, and these two septa divide the palm into three spaces. Divide the palm into three spaces. Now the space lateral to the lateral septum, that is that area, is called mid palm, the thenas space, and the space lying medial to the medial septum is called hypothenar space, and the space lying between the two septa are called mid-palmar space. So you have a thenar space, hypothenar space, and mid-palmar space. Okay, this is how the spaces are defined. Okay, this is what I just mentioned. Okay, three spaces: thenar space, hypothenar space, and mid-palmar space. Now, this hypothenar space, which is this one, which actually contains this hypothenar muscles and all, that space is clinically not very important. Okay, so you are not questioned on hypothenar space very much when it comes to infections and all. Then the thenar space, which lies lateral to the lateral septum here, this is the medial septum. The thenar space is important, and the mid-palmar space is also important. So remember this point. There is little bit more details than this. I removed some of the slides so that it becomes simple to you, or simple to all of you. Okay. Now all these lumbricals, the three lumbricals and one lumbrical there, they lie in these spaces. Okay. Index finger lumbrical and the other three lumbricals lie in these spaces: thenar space and mid-palmar space. Then the fibrous flexor sheets. Now this is the phalanx of the finger, and this is the fibrous flexor sheets attached to the anterior side of the phalanx. And this fibrous flexor sheets with the bony phalanx forms again fibroosseous tunnels like carpal tunnel, even though these are small. It forms a fibroosseous tunnel. So you can see the fibrous flexor sheets here, okay, forming the fibroosseous tunnels. So they are absent or weak where there are interphalangeal joints to allow the fingers to bend. Then the long tendons, flexor digitorum profundus and superficialis tendons, pass through these fibroosseous tunnels. So you can imagine that the function of fibroosseous tunnels is also like the function of retinacula. They prevent jutting out of tendons, and they make the muscle contraction more efficient by allowing the tendons to pass through the tunnel. But then the issue is there can be a lot of friction inside because the tendon is passing inside the fibroosseous tunnel. To minimize the tension between the fibroosseous tunnel, fibrous flexor sheath, and the bone on the other side, between that and the tendon of the long tendons, there is what is called a double-layered synovial sheath filled with synovial fluid inside. Okay, filled with synovial fluid inside. So on one side it will be open. It's like, it should be understood like the arrangement of lung and its pleurae. You haven't done the lung yet, but it's like this. You know, this is how you understand it. You fill a balloon with water or air if you want, and push it from one side. And push it from one side. If you push from one side, it will be like this. So it's a double layered thing. And if you push with your fist would be here. Okay. So if you push it further, what will happen is you will have a double layer like this. Okay. The two layers are connected here anyway. So you have access to the whatever, if it is the lung, you have the lung root coming out here. Now the same thing with these tendons. Okay. So there is one place where it is usually, it's open. Okay, very small place. So inside is you get fluid to relieve friction. Okay. So if you go a little bit more into the details of synovial sheets now, lying between the fibrous flexor sheets and the long tendons. This is how the synovial sheets are arranged. Now there is a synovial sheath for the flexor pollicis longus. If you remember the flexor pollicis longus, forearm muscle, there is a synovial sheath, a separate synovial sheath for the flexor pollicis longus muscle. It runs all the way through the palm into the carpal tunnel, and even a little bit proximally than the carpal tunnel, and stops there in the distal end of the forearm. Then similarly, the long flexors of the little finger also have a separate synovial sheath. Okay, separate synovial sheath. It enters the palm, and inside the palm, it becomes a common synovial sheath, which is common for second, third, fourth, and fifth long tendons. So it forms a common synovial sheath here. Okay, but here is a single synovial sheath, which is a continuous one. And this one is called ulnar bursa. Previous one is called radial bursa. Okay, previous one, which is around the flexor pollicis longus, is called radial bursa, and this one is called ulnar bursa. Okay, so that is one point that you have to remember. Then the other point is, when it comes to second, third, and fourth long flexor tendons, again there are synovial sheaths. You can see here, there are synovial sheaths. These synovial sheaths, they stop immediately proximal to the metacarpophalangeal joints. These are metacarpophalangeal joints. So synovial sheath stops immediately proximal to the metacarpophalangeal joints. Then there is a bare area of the tendon. Then only the common synovial sheath, which is called ulnar bursa, starts. Okay, so that you should remember, because synovial sheaths are important to remember. Okay, then about 50% of the cases, this ulnar bursa and radial bursa, even though it appear to be separate, in 50% of the cases they communicate here. Okay, so if there's an infection coming through this can, those 50% of the cases can spread to the ulnar bursa as well. Okay. Then from these bare areas of tendons, you get the lumbricals starting and getting attached to the distal end. Okay. Now, even though you don't have a bare area here, there is a thinned out area where the lumbricals take origin from. Then on top of the same picture, if I draw the other structures, superficial structures, this is the fibrous flexor sheets there. Okay, because the synovial sheets lie underneath them, fibrous flexor sheets. Then if I put the Palma Aponeurosis, this is how I can put the Palma Aponeurosis. There are 4 slips. You can see 1, 2, 3, 4 slips of Palma Aponeurosis, and these 4 slips, they divide. Each one divides into 2 slips and gets attached on either side of the proximal end of the fingers. They might be attached to the fibrous flexor sheets also, I don't remember. Then if you put the skin of the fingers, the skin in between the fingers, this is how you put the skin in between the fingers. Okay. Then if you look at your hands, so this is the skin between the fingers. Okay, that I have shown there. Okay, and if you bend your fingers and try to locate, you can easily locate metacarpophalangeal joints here at the back. Okay, but on the palm side, it's difficult to locate it. It's not here, it's here. Okay, if you bend it, you can locate the metacarpophalangeal joints. Now, if you put one of your fingers at the metacarpophalangeal joint and one at the skin. One at the skin. Can you see it? So this area is called web space. Okay, that gap is called web space. Now come back to the diagram, you will understand it then. So this area, these are web spaces. There are 3 web spaces there. Okay, and these web spaces are there's very loose tissues in that. So if you damage that area, if you prick that area, infection can settle in and infections can spread into the palmar spaces, especially the mid-palmar spaces, if you damage it here, because these lumbricals that you can see here, they connect the web spaces to mid-palmar space. Okay, web spaces to mid-palmar space. That's the important point that you need to remember, because these lumbricals, they pass through a small gap here, which is called lumbrical canals. Okay, so through the lumbrical canals, infection can spread from the web spaces into the palmar space. Then another clinical condition called tenosynovitis. Tenosynovitis is bacterial infection of synovial sheets, the sheets that we just discussed. Now, usually it is due to a penetrating wound, like you get accidentally pricked with a needle or a pin or something like that. So the infection goes into the synovial sheets, and then there's pus, you get infection and pus getting collected in the between the 2 synovial sheets, which is an extremely painful condition. Extremely painful condition. Usually the finger is kept in a partially flexed position. If you try to passively extend it, if the examiner tries to extend it, it's very painful. Okay, it's very painful because the pressure increases inside. And then, if it is not treated well early with antibiotics, then the pressure increases with the increasing collection of pus, and the synovial sheets can rupture proximally into the mid-palmar or thinner spaces. Okay, and then the infection can spread into the forearm. We'll come back to it later. Okay. So remember tenosynovitis, infection of synovial sheets. Then I said the infection can spread into the forearm. There's a space in the forearm also, which is called, either you can call it forearm space, or there's a specific name, you call it space of Parona. Okay. Some people use both terms and they call it forearm space of Parona. Okay. So the space of Parona lies between the different books give different versions again. Deep to the space lies pronator quadratus muscle, if you remember, pronator quadratus muscle, and the interosseous membrane between the radius and ulna. And superficial to the space lies the flexor digitorum profundus and superficialis muscles. Okay, so between these two, you get the space, and this is where the space is. This red area is the space of Parona. This is pronator quadratus. These are flexor digitorum profundus and superficialis muscles. Now, if you remember the attachment of flexor digitorum superficialis, it's attached to the it's attached proximally, close to the elbow joint here. So infection will be limited. Spread of infection will be limited at the oblique attachment of the flexor digitorum superficialis. That is, distal to the elbow joint. Therefore, infection will not go up to the elbow joint. Okay, at least it does not cross the elbow joint. Okay, it goes up to the upper attachment of the flexor digitorum superficialis and gets limited there. Okay, but nowadays, you don't see this these complicated cases of mid-palmar space infection and forearm space infections, unless they are uncontrolled diabetics, because there are very strong antibiotics now. Immediately when the doctors see these conditions, even at tenosynovitis level, they will immediately treat them, and then that's the end of the infection. Okay, but before the era of antibiotics, these cases must have been there. A lot of cases must have been there, especially with manual workers. Okay. Then there's another infection, pulp space infection. Pulp space infection. Now, pulp is this the area of the finger in front of the distal phalanx. Okay, so this is the pulp of the finger. Now, when the pulp space gets infected, issue with the pulp space is that it's something like this. Now, if you take the pulp, this is the pulp, the other way, okay. So if you take a pulp here, in the pulp, if I draw the finger, okay, if this is the finger, anterior side, and if this is the distal phalanx, this is the pulp. Now, inside the pulp, there are tough fibrous tissue bands like this, that from side to side. Okay, so if there is an infection, there's an infection in these spaces, to relieve it, and that is one point. That is one point. Other point is the digital nerves and arteries, they run along the long axis of the finger like this, laterally on either side. Okay, they run like this. Now, all these conditions, when they get infected, you have to cut and relieve pressure, like in compartment syndrome, because these are also small compartments. So if you don't treat it, pressure increases, then the blood vessels get compressed, and anyway the distal phalanx is going to die because of lack of blood supply. Okay, you remember Bachmann's ischemic contracture? It's also like this. Okay, so what the doctors do is they cut and relieve the pressure. So no point in cutting like this direction. If you cut in that direction, you might only cut one or two spaces. Okay, and then you have to put multiple cuts like this there. Okay, so to avoid that, what you do is, if the finger is like this, you cut along the long axis of the finger, and then you open it up and remove the pus from there. Okay, so when you cut even along the long axis, and the other advantage of cutting along the long axis is that since the digital vessels are there, if you cut like this, you will definitely cut them. If you cut in that direction, you are cutting parallel to the long axis of the vessels. So the chances of cutting them is very low, especially if you don't go too laterally like this, because the digital vessels are there. You cut slightly laterally away from the vessels and nerves, then you can protect them. Okay, so in this diagram, actually it has been shown that it's cut in the middle. Usually it's not cut in the middle like this. Okay, so this is not correct exactly, because that is the area where you touch and feel. Okay, so cut should be a little bit lateral. Okay, so this is pulp space infection. Usually these pulp space infections, they usually of their own, they don't spread into the synovial sheets. Okay, so don't say that the pulp space infections become synovial sheath infections and cause tenosynovitis. Usually tenosynovitis is due to a direct injury to the synovial sheaths by a prick or something. Okay, then few points about lumbricals and interossei. Lumbricals and interossei, they are intrinsic muscles of the hand, together with thenar muscles and hypothenar muscles and adductor pollicis. These are also intrinsic muscles of the hand. What you mean by intrinsic muscles is that the origin and insertion of these muscles lie within the perimeters of the hand. Extrinsic muscles, they have the origin outside the hand, insertion inside the hand. All long flexors and extensors are examples of extrinsic muscles of the hand. So lumbricals and interossei are intrinsic muscles of the hand, and lumbricals, you know, there are 4 lumbricals. They take origin from the long flexor tendons, flexor digitorum profundus tendons. There are 2 lumbricals taking origin from the lateral 2 tendons, and they are supplied by the median nerve, because the flexor digitorum profundus, if you remember, flexor digitorum profundus, it has 4 tendons like this. Flexor digitorum profundus, if you divide the muscle into 2 halves, lateral half is supplied by the median nerve, medial half is supplied by the ulnar nerve. Okay, going by that, the medial 2 lumbricals, 1 and 2 lumbricals are supplied by the median nerve. 3rd and 4th lumbricals are supplied by the ulnar nerve, because of the nerve supply of the muscle, dual nerve supply to the muscle. Okay, so that is one point that you need to remember. Then when it comes to interossei, there are 2 groups of interossei. There are Palma interossei and there are dorsal interossei. Palma interossei pad Palmar interosei adduct the fingers, dorsal interosei abduct the fingers, pad and depth, that's how you remember it. And all the interosei, whether they are palmar or dorsal, they are supplied by the ulnar nerve. Okay, so if I summarize it again, lateral two lumbricals are supplied by the median nerve, medial two lumbricals and all interosei, both palmar and dorsal interosei, are supplied by the ulnar nerve. Then these interosei and lumbricals, they are both inserted to the extensor expansion or extensor hood at the back of the fingers, to which the extensor tendons are attached. Now these are long extensor tendons. They actually not attached. The long extensor tendons expand at the back of the fingers on the dorsal side and form these extensor expansions, or you call them extensor hoods. Extensor hood. Okay, extensor hood or extensor expansion. So the lumbricals and interosei are inserted into the extensor expansion or extensor hoods. At the same time, you can take as both, but it's usually interosei are also attached to the base of the proximal phalanx. Base of the proximal phalanx is somewhere here. Interosei are attached there. So ultimately, the action of lumbricals and interosei together, you can separate the action and give the action separately, but I recommend that you take them together and give the action. Okay, the action of lumbricals and interosei is to extend the interphalangeal joints by acting through the extensor expansion. Okay, because when the tension increases in the extensor expansion, the interphalangeal joints tend to extend. Then because of the attachment to the proximal phalanx here, especially the interosei, when that contracts, the metacarpophalangeal joint flexes. Okay, so overall action of lumbricals and interosei is to extend the interphalangeal joints. Okay, it is the extension of the interphalangeal joints and flexion of the metacarpophalangeal joints. Extension of interphalangeal joints and flexion of metacarpophalangeal joints. Now remember this point, I mentioned this when I did the Walkman's ischemic contracture also. Now this, I said they extend the interphalangeal joints. When they extend the interphalangeal joints, they oppose the action of long flexors. Long flexors, they flex the interphalangeal joints. So lumbricals and interosei oppose that action and balance it in a way. Okay. On the other hand, their action on the metacarpophalangeal joints, the flexion of metacarpophalangeal joints, is actually opposing the action of long extensors here, because they tend to extend the metacarpophalangeal joints. They tend to extend the metacarpophalangeal joints. When the nerves are damaged, you get this balance disturbed. Therefore, you get certain deformities like ulnar claw and full claw and so on. Okay, so remember these points. These are very important points. Okay, that we question in different places. Okay. Then the first one, the ulnar claw hand. Ulnar claw hand. Now, in this person, you can see that this is ulnar claw hand, this is due to damage to the ulnar nerve. This is due to damage to the ulnar nerve. Now, we'll say that the ulnar nerve is damaged somewhere here, either in the Guyon's canal or even at the wrist. If there's a cut here, at this level, at the wrist, okay, an injury, then you get this picture. Now, look at this ulnar claw hand. Now you can see the little finger and ring finger, the metacarpophalangeal joints are extended and the interphalangeal joints are flexed. Why is that happening? Because the ulnar nerve supplies all the interosei and the medial two lumbricals, the lateral two lumbricals are supplied by the median nerve. Now, because of the loss of both lumbricals and interosei of the ring finger and little finger, okay, their action is gone. Therefore, flexors, long flexors, flex the interphalangeal joints, and long extensors extend the metacarpophalangeal joints. So that is the reason. Then why is that less on the other side? Because that side, the two lumbricals are intact. Even though the interosei are gone, when it comes to index finger and middle finger, since the two lateral lumbricals are intact, they can actually, to some extent, counteract the action of long flexors and extensors in the resting position. Okay. Therefore, there is no clawing much there. Okay, so it's ulnar claw hand because it's like this now. It's like this now. In the previous picture you saw, full claw hand is something like this. Okay, full claw hand is something like this. Ulnar claw hand is something like this. Okay, so this has to be extended. Okay, it's difficult to do it without getting. So these two are fine. Okay, these two are fine. This is like this. Okay, so that is ulnar claw hand. Then there is another phenomenon called ulnar paradox. Ulna paradox. What is a paradox? Paradox is something that you see something that you do not expect to see, or you see the opposite of what you expect to see. That is the paradox. Okay. Now, what is the paradox here is that now if you have a nerve like this, okay, when the nerve goes from, if this is the proximal side and if this is the distal side of the limb, then the nerve goes and gives branches. When the nerve gives branches, you cut the nerve here. Okay, this is A. Or you cut the nerve here. This is B. Now, if you go by normal, the expected observation, if you cut a nerve at A, the deformity should be less, because most of the structures that are supplied by the nerve in that area, proximal to the cut, is spared. Only the structures supplied by these branches will be affected. Okay, so if you cut at A and cut at B in two persons, the deformity is more when you cut at B than when you cut at A. Now here in ulnar paradox, what happens is that if you compare the ulnar nerve damage in ulnar paradox, now if in this case we thought the injury was at the wrist joint, so you got this ulnar claw hand. If the injury was not at the wrist but at the elbow joint, you expect whatever the deformity to be more than this, because the nerve is cut at a proximal place. But quite contrary, the loss is actually less. The deformity is actually less than the deformity you get when you cut at the wrist joint. Because the reason is, when you cut at the elbow joint, the medial half of the flexor digitorum profundus is also gone. Initially, the medial half of the flexor digitorum profundus supplied by the ulnar nerve was intact. Okay, was intact because the damage was distal to that. Now, in this instance, when it is cut at the elbow joint, the nerve supply to the medial half of the flexor digitorum profundus is also gone. Therefore, this effect of flexion produced by the tendons of the flexor digitorum profundus is gone. Therefore, this interphalangeal flexion becomes less. Okay, so you see a less clawing of the fingers, lateral to fingers. Okay, so that is why you call it ulnar paradox. Okay, that is why you call it ulnar paradox. Remember this explanation of ulnar paradox. Then median nerve damage at the elbow joint. So if you damage the median nerve at the elbow joint, not like ulnar nerve damage, because in the forearm, if you remember correctly, the ulnar nerve supplies the flexor carpi ulnaris muscle, which is a wrist flexor and a wrist adductor, flexor carpi ulnaris, and the medial half of the flexor digitorum profundus. Those are the only structures supplied by the ulnar nerve in the forearm. But the median nerve supplies all the other flexors of the forearm, and also the pronators of the forearm, pronator teres and pronator quadratus. They are all supplied by the median nerve, so it's a huge supply. Then other than that, when it comes to the hand, it supplies the thenar muscles of the thenar eminence. Then it gives cutaneous supply to the lateral 3.5 fingers. So it's a huge area of supply. So if you damage the median nerve at the elbow, obviously the pronator muscles of the forearm are paralyzed. So you cannot pronate. Instead, the forearm is kept in supinated position due to the unopposed action of biceps brachii and the supinator muscle. Okay, so that's one point. Then the second point is, long flexors of the wrist and the fingers are paralyzed, except for flexor carpi ulnaris and medial half of flexor digitorum profundus, which are supplied by the ulnar nerve. So the remaining parts are, all remaining muscles, long flexors are paralyzed. So Therefore, as a result, wrist flexion is weak, and the finger flexion is also weak, and the wrist flexion is accompanied by abduction, because the reason why it is not abduction, it's accompanied by adduction. Okay, adduction. Okay, so I could not correct it, because the flexor carpi ulnaris is intact, so it adducts. Okay, abductors are gone, flexor carpi radialis is gone. Okay, so it's weak flexion accompanied by adduction. Okay. Then no flexion is, for the same reason, no flexion is possible at the interphalangeal joints of the index and middle fingers. Index and middle fingers, interphalangeal joints, you cannot flex because it's solely by the long flexors, flexor digitorum profundus and superficialis. They are totally gone, but there's weak flexion of metacarpophalangeal joints of the index and middle fingers by the interossei muscles. Okay, because they are intact when it comes to the index and middle fingers. Okay. Then when tried to make a fist, if you ask the person to make a fist, the index and the middle fingers, they remain straight. As you can see here, they remain straight. Okay. Whereas the ring finger and little finger easily flex because of its the tendons coming from the ulnar nerve supply half. And this sign is called benediction sign. From this view, when you look at it from this view, you will say that it is like ulnar claw hand, but it is not. Okay, because there is no extension of metacarpophalangeal joints as such. Okay, so it's benediction sign, and this is not a resting position. This is when the person is trying to make a fist. Okay, so this is the fist he can make. Then the flexion of the terminal phalanx of the thumb is lost because of the paralysis of flexor pollicis longus, another long flexor muscle supplied by the median nerve. So the thumb is kept straight, and the thenar eminence is flattened because of the atrophy of muscles. I told you about atrophy. When the muscles become smaller and smaller due to lack of nerve supply, you call it atrophy. Atrophy can be due to other reasons as well. So then the thenar eminence, the prominence is lost. Then the other important thing is the thumb. Usually the thumb can be opposed against other fingers, which is called opponents, action of opponents. And in apes cannot do that. Okay, now this is an ape hand. In apes, thumb is kept at a side. They cannot oppose the fingers. They cannot oppose this one to this one, this one to this one, like that. Okay, so that is lost in the person with the median nerve damage. So this is what happens, is like an ape hand. Okay, so the thumb is extended and adducted. Because thumb, there are abductors here. Okay, short and long abductors. The short abductors are affected. Long ones are not affected because they are supplied by the branches of the radial nerve. So the short abductors are affected, but there is an adductor pollicis here, which is usually supplied by the ulnar nerve, that is intact. Therefore, the thumb is adducted and extended and adducted. Okay, because the flexors are also gone, thumb flexors. Okay, so that is called ape hand deformity.